We'll do this one first. Clinical reasoning. What do you prefer? Let's do this one. Okay, this is advanced health assessment. Today we're going to be doing health history. Who does a health history as part of their job?
We do.
We? Why do you say we? Like, we're talking individuals here. Like, do you in your job actually do health histories, like real health histories you take?
No.
So I saw someone over there does it.
Like brief. Like a brief triage.
But we don't. Wink, wink. It's like when they're in the bed, those med search, and we auscultate their hearts. Yeah, right. Bowel sounds times 4. Whatever. If they're eating and pooping, they must have bowel sounds. Something to keep in there.
I rather have some fun.
I know.
Something. Come on, I'm a nurse too, so I'm not that naive too. But hopefully this course is going to give you an appreciation. I'm really nervous about some of these before. Free hugs? Yeah, you can put that hug her break. Okay, so hopefully this course is going to give you a better appreciation for the work we do, right? It's going to teach you real skills. I know when you do your BSN, right? Usually you have your patient there in front of you, and then, I love this about BSN students, and you go, and then I would touch the head, and then I would palpate the thyroid, but nobody's actually doing anything. They just tell me, or they touch the neck, and go, and then I would feel the thyroid, and think, do you know where the thyroid is? Like, why are you doing that to that person, right? So then we're actually going to learn where this stuff is, right? And we're going to learn appreciation. We're going to try to put this in context of, why we do this stuff. Because, I guess there's that rule in anything in life. If it does not worth anything, why should you do it? Right? If your physical exams are a bunch of junkola, why do you do them? Why do you really put bowel signs up for? You're not checking anybody, right? No, I'm not looking at you, right? You know what I'm saying? Come on, people, right? Or if we're not really checking lung sounds reasonably, or if we bought, it's probably the problem where we're using that stethoscope we bought in nursing school. That's the junky one. You can't hear anything, and that hurts in your ears. It digs in, right? And you want it off fast. So we can't actually hear any heart sounds. You couldn't actually say if somebody had a murmur because you can't hear it. So you need to. Everybody have a good stethoscope? Mm-hmm. Anybody have a bad stethoscope? Get a better one. Get a good one. It really makes a difference because you can't hear junk with those other ones, right? So you can't really do a good assessment that you will be required as a nurse practitioner to be able to perform, that you will be held accountable for. You can't miss murmurs or rhythms or different heart sounds, right? Or changes in the lung function. So you need the right equipment on that. So part of what comes about in all this stuff, is also during this course, when you have another diagnostic reasoning course, is going to be clinical decision making. So you're kind of, you're moving up into a role where you're going to be required more capacity for thinking skills, going to be making more autonomous decisions, right? We could be fully autonomous in this state soon, right? We know House Bill 607, right? We're watching it. Everybody's writing to their reps and senators. Well, someone look it up. House Bill 607, look it up. Everyone look it up on it?
Hospital what?
Hospital 607. I think it's for
so clinical decision making is important because,
to open up their own
Matt,
clinic.
you know how long Washington State has had full practice authority?
There's a bill.
How long?
Pending.
Oh, no, how long? I don't know.
Yes.
No, I don't know.
No.
I'm sorry.
Anyone guess? That's courageous. This is like the 70s.
I know, what's
So
it?
you think the issues they deal with in their practices, do you think they just see pharyngitis and bronchitis all day long? Come on, man, right? We work in a state like under bondage or something like that. We're like residents for eternity. We never graduate residency, the way the structure is set up. And sometimes the education, unfortunately, teaches you to your limitations, not to your potential. So if you're a nurse practitioner in Washington State, you're going to see complex patients, and you have to know it. And you're not going to have a physician to back you up. You might say, in the hospital you have a physician giving you orders, so they should be coming around, but their physical exam skills are just as rotty, right? Who's seen a physician do great physical exam? It's not. It is possible, right? But it is a skill. It's an often neglected skill, but it does have value in the whole process. So remember, you're here to learn to your potential what it is. You're going to see complex patients. You may be now stuck seeing bronchitis, but that's not your future. Right? Your future is going to be autonomous practice. So you're gonna have to be responsible, so your skills are gonna have to be good, and if you don't practice your skills, you don't have skills. So this is kind of some of the stuff. Did anybody look up House Bill 607?
Yeah, I'm writing something.
Florida, you gotta look up Florida. Because then you kind of get all the other junk.
Your healthcare practitioners.
Authorizes autonomous practice for specified time.
There you go.
Requires Board of Health or DOH to register physician assistant or advanced practice registered nurses if applicant meets criteria. Authorizes such autonomous healthcare practitioners to perform specified acts without physician supervision or supervisory protocol. Provides appropriation and
She's not reading the whole bill.
She's
Oh, like in the Senate floor, and they read the bill 4 years ago. Vote yes or no.
So it says effective date 7/1/24.
So that's this is theoretical. If this doesn't go anywhere, it doesn't go anywhere, right? So autonomous. We sometimes nurses we don't like to use that term, right? Because it implies this idea that we like sort of do stuff independent of the healthcare system. No matter what we have, we'll always be part of the healthcare system. We're going to rely on collaborators, and we're going to work with other colleagues. You know, other people used to use a complex term like plenary authority. Has anybody ever heard of that? No. So plenary authority is really, where do you derive your authority to practice currently in the state? No? Well, it's statute, right? It's the law. What does the law say about your practice? So you have to have a collaborative agreement with a physician. And if your collaborative agreement disappears, do you know what you do in the office tomorrow? No. Nothing. They're not even going to let you sweep the floors. Right? So your practice is derived from that paper. Right? That's a strange place to have it, right? So if you have a driver's license, where does that authority to drive come from? The state, right? You don't have a middleman in between, right? You just drive, right? You have plenary authority. Your authority is derived from the state. So we don't. We have a middle person in between that controls our practice. And if your paper's gone, you don't practice. So I have an Arizona license too. I have full practice authority there, right? So if I fly to Arizona, I practice. Cool. I come back here, they put the shackles, and I come back. And I'm over there. I'm free, right? So what changes in my skills in between the travel, right? Maybe more radiation exposure or something. That TSA machine, is that thing safe? Be honest? Come on. Let's wait 30 years from now. Oh, by the way. You know? So yeah, so hopefully this course is going to kind of teach you this. We're going to, doing all these things are hopefully going to be part of it. Where do I begin? So health history is kind of the basis of it. It's a real skill to do it. So we're going to learn about how to do a health history, kind of make it. It's not always interesting to do, but it definitely serves a valuable purpose. And it can, and all this is a really process to. I hate to say like nurses are holistic. Do you ever hear that term like abused? I don't even know what it means anymore, right? It means like sometimes it means we want to be holistic, but we aren't holistic, right? Or something like that. What was that?
Because we can be holistic.
We can, and maybe we can, and maybe we can't be holistic, right? Maybe it's just something we have as a paradigm we don't actually ever access. So it requires actually like really doing it. And part of taking a health history is allow us to learn more about our patients and really putting their care in context. Say you work in a free clinic setting, they come in with asthma, you prescribe them, a long-acting, beta agonist, something like that, right? They can't afford it. So you haven't put that in their socio-economic context, right? I'm actually finishing my psych NP certification on my clinic today, and this guy, he's a little schizophrenic, and he's telling us he takes all these herbal medicine, right? He blends it up. Most people make teas with herbal medicine. They blend it up and drink all the leaf stuff. I thought that was a little much. Like there must be a lot of fiber though. But you sometimes had to kind of negotiate in the context of his culture. I don't want to say like, dude, this isn't working, right? I mean, this isn't working for you, right? But so you wanted to negotiate. So obviously, culture is a competency, and we got a lot of this theory on there, right? And we kind of get nauseated by it. I'll speak for myself. I could get nauseated by these theories if I don't have like some reality basis for them and how they fit together. But they do have a role in really seeing a patient in a meaningful way. And you get kind of brief moments in your practice where you think, well, that was really important that I negotiated that this guy. So we decided not to have him take this oral, like, and maybe he could apply it topically. He seemed to be okay with doing that. We thought it would be helpful. I don't care if he uses it as shampoo. Right, I mean, but I didn't want it to affect his medication either, because he's still kind of delusional, so I didn't really think that, this was working in his favor. Okay. So apparently 85% of all malpractice, now the serious part, lawsuits are based on poor communication skills. Who thinks they're a good communicator? Well, we got your skill.
I'm the talker.
Who doesn't talk? Well, no, yeah, so you're a good communicator? Anybody else? Okay, so many people, so communication is a learned skill apparently, right? I mean, if you don't communicate well, you just go home with your old garbage talk, right? You look at whatever your parents taught you to speak, right? And that's kind of what you pick up, right? How many people do things without habits? It's kind of a difficult question in the sense that sometimes we don't know we're doing habits. Right, we're so immersed we can't tell the forest from the trees. How many people know things because they heard it somewhere? Like, I know that's true because, maybe it was talked on Fox News or CNN for 2 hours. And then somehow that reinforced in the mind that there was some factual basis for something because people kept repeating it. So we get that kind of way with our communication. If we don't actually practice intentionality, we probably don't communicate well. There's a chance that we could communicate well, and that might just be by random chance, but probably we just communicate average. So it is really important to kind of interview. This is just more stats on this. I think if this is anybody ever watched a very good interview? Give me an example of a good interview you saw.
Like an interview, like a patient
Well, anything. It could be a patient, but just an interview on TV. Someone interviewed somebody and it was good.
Oh, I just have a doc who's really good at interviewing.
Okay, so you know the physician who is. Yeah? Anybody else? I saw someone, actually this, Larry King, when he was dying, Piers Morgan took over or something, and he had the Dalai Lama on. And the Dalai Lama, right, whatever your sort of personal beliefs is, he's kind of a chill guy, right? Like, he's not like a bad guy. You can just tell him. You may not have to believe everything he says or have his beliefs in line, but he's not a bad guy. You can just tell this, right? So he's interviewing him, and this is not easy to get an interview with this guy. Everybody who knows who the Dalai Lama is, right?
Of course.
So, what does he ask him? Has he ever had sex before?
He
Even if
asked
he did,
him.
who cares?
He
Right?
asked
Like,
him.
you have a guy who's purportedly kind of has some spiritual ideology. You might like to learn some wisdom from the guy. You ask him some trashy things like, "What's your favorite music?" Like, who cares? He listens to Tibetan chants, whatever.
I know.
Right? Like, that's not a good interview, right? That is like a nonsense of you have an excellent person in front of you and you kind of waste it on some silly questions on there, right? So interviewing is like it's a tag team, right? It's the person who interviews and the person who is interviewed. And everybody has to have their appropriate amount of space to talk. Who's had patients that kind of ramble?
Oh, yeah.
So does that make for a good interview or a bad interview? Of course, you have to keep it focused, but you can't run it militantly. Right? People have to feel like they get to express themselves, but they can't kind of ramble on forever. Because sometimes you have other patients and you can't spend all the time there. So interviewing skills is really, it's a talent. It's a talent to be able to control the interview without making it as though you're controlling. And that's when you see good interviews done on TV, for example. People guided with good questions. They have thoughtful questions, meaningful questions. Right? I have to laugh. Some of the students in the program, they're working on their full degree. And, they don't even have a master's yet in psych. So I have an FMP, so it's easier for me to transition to a psych. So he's kind of new. He's an RN too. He's asking, and this person's talking about their delusions, another patient. It was like a rabbit hole. Right? There was no end to it. It was all kind of made up, right? Now, he wasn't making it up, he believes it. But you can ask him, well, what was in the delusion? What color was the monkey? He could just go on forever. It's like a fantasy world, all right? And he kept asking him questions. We're not going in the right direction. I mean, we're not really finding if this guy's functioning on life and he's kind of generally happy with his condition. He can't take the delusions away, but if I follow down the rabbit hole, I'm just wasting a lot of time with this guy. Right, and it's not helping him because I really don't care that much about all the intricacies of his fantasy. Like if you used to tell me about your dream last night, I was like, "Well, what happened? And did they really? You won the lottery in the dream last night? Wow, how much did they pay out?" Right, it's kind of in the end, it's just a dream. And you're like, "Okay, that's nice." So interviews are like that. They require regulation, being able to ask meaningful questions, and being able to guide when answers are sufficient as well too, to keep it moving. So, these are parts of the interview. These are very basic stuff that we kind of get right. Of course, we always know our demographic. Ideally, we know the culture, the source of the history, whoever's telling it. Oftentimes, when we're dealing with children, we have a parent who's speaking on their behalf. It should be identified when you take a history, who is giving it. Oftentimes, maybe in psychiatric, you have group therapies or something, or family therapies should be known, and then a sense of what the reliability of that person is. Right? Obviously a schizophrenic who's delusional, his reliability is kind of low on some things. But you also have to watch for weird dynamics between family members as well too. So that's important to kind of know what the reliability of the information is. It's not uncommon that you actually write that, who the source of the information and what your perceived reliability of the patient is of that. So, and we know that patients are commonly bad historians, right, about their history. I mean, that could be one. What are reasons for that?
They might think it's like taboo, whatever.
Taboo could be issues they don't want to talk about. Like on your first visit, you ask about their sexual history, and you say, you start getting into this, like, what's your birth sex? What's your gender? What do you identify, your man, woman, non-binary, right? Who do you have sex with? Their orientation, and then, do you have any high-risk sex? Do you anal sex, oral sex? People are like, people may not be willing to share information like that, especially if they're kind of doing like the close to the normal stuff. They might share the normal stuff, but if they do like something freaking on Friday, they might not be willing to say that this is how they engage in this behavior, right? So taboo or drugs, sometimes you go, do you use any illegal drugs? Like what am I, the DEA or something?
Yeah.
And then as soon as you do it, they come suck them out, and then they say, like another sucker gone, and they stay in prison for like. All right, so it's like that's not the intention of what we're doing either. So maybe there's a better way to get information. So taboo. What are other reasons?
They sometimes don't tell us as nurses, but they'll tell the physician.
Or
Or
sometimes don't think you're
sometimes,
some high ranking, and they don't want to
Yeah.
repeat the story.
or they'll say, "Oh, that's not important. That's not why I'm here. I'm not here for that." They'll tell me
That's
that.
very good. Yeah, I've seen that
You
all
know?
the scenario. This person goes
Yeah.
and gets it, this person gets this information, this person. Okay, so that could be there. Anything else?
But I just forget.
Forgetful, just forgetting. And forgetting, remember, also relates to the fact that people don't remember things. In the sense that you have to make memories to forget them. If I said to you, what did you eat last Friday for dinner? Maybe you didn't put the energy to like store it in long term, right? Or if I said a month ago, what did you have for dinner on December 23rd? You didn't have the energy to put it into memory, right? It stayed in there, short-term memory, some neurotransmitters were popping around for a while. You can kind of remember it, then you didn't commit it to memory, and then it. So remember, they don't prioritize the things the way we do, so they just don't pay attention. What medication are you on? I don't know. They don't somehow think it's important either. So they don't make a memory, so they don't actually forget it. They just don't memorize it. So a lot of reasons our job, and this is where sometimes, as an F&P role, over time we can build relationships with patients, make connections so that, maybe they can tell us more information over time. And you always take the information with a grain of salt. You don't have to have absolutely 100% information to come up with a treatment plan and a diagnosis and to work with your patient. That's not really that essential. Okay, some rules, of course, right? Interviewing, setting the right milieu, the environment, right, for that. They should perceive you as professional would be one thing. What else should they perceive you as the provider? Empathy is good, right? Not pathetic. Empathetic is better, right? They're pathetic. They're weak. They're weak-willed, I can tell. Okay, anything else that they think that they might?
Patient advocate.
That you're on their side a little bit, you advocate. What else?
That you know what you're doing.
Knowledgeable is probably good, right? So I think those are kind of, and there might be some other like specific qualities, but those are kind of the things you want. You have an empathy of the heart. You have actually a knowledge of skill. That's a good combination, right? You look your part a little bit. Maybe if you have a title, you might sound Dr. Schlepko. Sometimes I do. It depends on how I know and what I think the impression is going to be for them, right? And then I guess the last part, cultural humility. That's just being culturally competent. We're that there are other cultures, but I don't think you're obligated to know every culture, right? You cannot. It's not easy to. My wife is Hispanic, and I can't really say like I can put my brain in her mind.
Yeah.
and understand what it's like to be Hispanic, I kind of got a feel for like what's going on, but it's not exactly like what I think, you know what I mean? But I kind of understand some things, and I think some of it with cultures, if you make a good intention, it's like if you go, who's been to Europe? Well, who's been to a country where they speak a language other than English? I mean, do you make efforts to like speak in their language a little bit?
Yeah.
Seems like that. I mean, the worst are like, I don't speak English. No, I don't speak English, people. Right? I mean, try to adapt to cultures. Try to understand that people could be doing things and engaging behaviors out of cultural. This was a story recently, right? This is a Jamaican, family explaining this, that it's not uncommon that when they have something on their mind, like a sense of a premonition, right? Like if they had a dream, that they might go, if they're in a small town, to like the public square and tell people about it, like, oh, the end is coming, or this is bad, it's going to happen. And that's kind of culturally normal. We would think that's like, not how I think most culture here would manage that kind of situation, but that would be considered normal. They're not psychotic people, right? It's culturally normal, right? Who would go to the center of Barry, right? The main square and preach something about their dream, like the end is near. I had this dream and I want everybody to know. I don't think probably too many people. But that does happen, right? So I think if we make efforts to understand that, it'll make a difference. I think humor probably lends itself better just to loosen people up a little bit. I guess it can backfire once in a while, right? But pros and cons, some of them don't understand. Have you ever been in a country where people don't understand your jokes? I was into Ukraine and I was traveling on my own. That was kind of bad, right? It's kind of a lonely feeling when people don't understand you at all, right? Yeah, I found stuff very funny, this is me. So, it was one time it was winter. I got like a ticket for $400 or something to fly to Kiev, and I had a friend like, whatever, let's do it. This is a dangerous thing. I mean, it's a terrible time to be there in the middle of winter, you can imagine. But they do wear that big like hat, like it's a bear on their head. I had to laugh. I thought it was so funny because it's so stereotypical, and nobody thinks that's funny. You want to be like, I mean, the thing is huge. I mean, it's warm. I had like a little hat. I was coming from Clearwater, Florida, so I didn't want to invest in a coat. You know what I mean? Not that kind of coat. So I just like 5 coats. None of them were actually ever sufficient, rated for that temperature at all. So I'm thinking, but I was kind of lonely there. You can't even share like at the end of the day. Like, isn't that fun? No. Okay, guys, you're missing out. Okay. So a lot of what we do with interviewing is also being able to determine priority. You haven't started to see patients yet, have you? So patients come with a lot of issues. They come with a lot of problems. So it's your job to kind of find out what you can talk about in a certain amount of time, like 20 minutes, for example. Right, and that's kind of important that we, really be able to stick to that sort of time, for many reasons. Maybe it's not enough to get into a lot of things, and maybe there's time you can spend more time with them. And maybe we should all spend 40 minutes. And, there's always a moment to be empathetic and connect with a patient at any time. But the fact is we have to be able to prioritize and figure out what's really important and what we can work with. Because remember, when they come in like a wreck, who's seen a patient that's like a wreck?
Yeah.
They took a lot of effort to get to a wreck state, right? That's a lot of austerity and practice. So it's like an old car coming in, right? You're going to fix up the car. You don't do like everything in one day. You just have to prioritize what's going to be most important to get them running again. And then you can really, but you have to be clear with that. And because you'll find in clinic you suddenly get overwhelmed. Like, juggling, you can do 2, 1, but then they throw a ball at you and you miss them all and then one hits your head. And, you ever seen that when you just drop a ball? And that's what can happen when patients come in really complex and you're not really kind of prepared for it. And if you have possible at the end and you're a good communicator, just kind of summarize everything you want, right? Make sure in the health history that you understood what they said and you give them an opportunity also to correct you. In case you, have you ever seen that where people give a report to somebody else like an attending and then it may not even be right for the patient? They're kind of like just talking to the patient there. It's not as bad as it used to be, right? Where the med students used to gather around the patient and call them patient X1, 2, and then in essence they poked them a little and ran out of the room or something like that. But asking the patient to make sure that what we're catching is really what they're conveying to us. Okay, this is different ways to evaluate understanding. So some tips on that, right? Yeah. So I think some of this is the patient gives a self-diagnosis to consider how does this fit with what you were thinking. You know, this is validating what they say. All your patients, of course, want to be highly validated, right? They were like, well, that's stupid, right? You know, this is an age where they come in with Google and phones and look up information. And we may feel threatened that they come with information, but I don't think we should really feel threatened. You should be encouraged that people look up information. They could be much worse, right? I mean, I always find it surprising when we get a patient. They're usually old school patients, I'll call them. You know, where they're like, whatever you say, doctor, I trust you. And I'm like, why are you trusting me so much, right? I was like, don't trust me so much. I would prefer you to be a little critical of me. Jesus Christ, I need someone looking out for me. You know, like, don't trust me because I have a title, right? We can work together as partners. You know what I mean? But don't trust me so implicitly, right? But asking, validating where they're at. Even if they're wrong, it might be a chance to educate or move them in a different direction in their thinking. The history. Okay, chief complaint. So let's go around the room. Tell me how you might do a chief complaint. Let me say what it is. This is really what they're here for. So someone give me an interview of how you would ask about the chief complaint.
We'll go to the hospital.
Let's do one, and we'll pick someone else. Who said that?
We'll go to the hospital.
What brings you to the hospital? What brings you to the clinic today? That's good, right? Maybe a one-liner, you're writing chief complaint. So it's not your diagnosis, obviously, it's just what they think. And sometimes it's written as quotes, right? What that is. History of present illness. Who wants to handle that one? How would you say that? This is a little more description of the chief complaint, giving you a little historical information about maybe it began 2 days.
So when did your symptoms first begin? In my case, it began 2 days ago.
2 days ago. Is she infectious?
Yeah.
Well, she was probably infectious before that, probably at least 24 hours, right? You know, you were probably viral shedding before, right? And you're probably still viral shedding because you haven't probably consolidated your mucus yet. You're not done yet. So she's shedding.
I'm not.
Okay, so that's one way to do it. So you might also ask any of these questions as well too, right? So sometimes you see these old cards in different ways, you know. You don't have pretty much, so you might ask about, okay, so what symptoms you're having?
I'm having hoarse throat, phlegm, coughing,
Okay, okay.
sinus, congestion.
So what is your cough like?
It's productive.
Okay. It's productive, but is it a harsh quality of sound? Is it dry? Is it wet? It's wet, okay. You say that's, you know,
Painful.
it's painful, and painful too, right? So when you say painful, you mean like painful when you actually cough in your throat or in your lungs? You feel that in your chest? Okay. Are you having pain at the moment?
No.
Okay, and then how would you rate your pain between 0 and 10? 0 being no pain and 10 being the worst
About
pain.
a 5 when I cough.
Okay. So anybody ever disagreed with their patient about what they thought their pain should be?
No.
No, come on, be honest. Be honest. Like, you guys thought they're not right. Come on.
I'd be like, you have so much pain when you're on that cell phone.
Think of this as like therapy too. Let's get it out. Let's get it out. Am I making it up?
Sorry.
It's good. You can be okay. So yeah. So okay. So this is like therapy. Let's get the junk out. Let's be honest about where we are tonight. We can't really grow if we don't know where we're at. You know. So we oftentimes disagree. I don't know what, you know. Honestly, I can't say I don't know what the value of that is. Right. Disagreeing too much. Right. Just let it be what it is. You know. The rest of your documentation will support or not. Right. It's not the only factor. Right. We know a scale rating is subjective. Right. On there too, so you're going to put it in context of everything else.
Here are some movies matching factor.
Oh, yeah, that's excellent. So what makes this pain better or worse?
My little house cough.
Oh, the little ones, okay. The big ones are better. Okay, so the cough drops, they help out, right? So they make it better so you cough less, right? Is there any other signs or symptoms you're having?
I think I had a fever.
You had a fever. Did you measure it, or is that just something you
No, I
feel?
just felt sweating.
Okay. So she reports a subjective fever, right? So that might be a way just to develop an HPI by kind of seeking questions like that. You can use different mechanisms, gold cards, onset location duration, characterization, right? Leading and agreeing factors, so, and temporal factors. Okay, HPI. So it's a little bit of past medical history, right? I mean, they kind of make it like it's all past medical history, but it's not really. We're only just relating it to this. So you can see interviewing is fun so far, right? Okay. So again, this is just another tool to be able to break out, right? Sometimes the cough maybe is asthma related or something like that, and you say, does it occur at this location or that? Is the environment important, right? Does it occur at work and not at other places? And not always appropriate for everyone, but if you kind of, and I recommend you kind of pick one of these tools to stick with for your development, because I think, well, the issue is really, I know everybody knows how to shortcut, right? It's wired into us, right? If everybody could do things easier, would they do it easier or harder? Be honest.
Easier.
Of course, right? We're all wired that way. But I would like you to learn to go through these kind of either you can use locates, you can use old carts, until you get really good at it. And then I think once you get good at it, you can learn the right way to shortcut things. But otherwise, you kind of shortcut in a lazy way. Have you ever seen kids who don't seem to, like, adolescents who haven't seemed to really master linguistics, and they use like the F word for everything? And you're thinking, like, there has to be a rule. Everybody knows the F word, right? Okay, so there has to be a role for this word in society, right? So what is this role? I'm not like a real strict, what a terrible word, right? I mean, but it seems like you should be able to master a good vocabulary and then use it appropriately. Like if you bang your thumb with a hammer and you go, something like that, right? That could be a good time to do, but you can't do it. F and this and F and that, and you're that sounds like it's just overusable. Like you don't have enough adjectives to describe situations, right? In the end, it gives very little information about situations. You're like, I don't know if you mean people, you hate people, you like people, you got a good compliment, is that a, So it's like, and this is the same way. Learn the right way to do it. It's my suggestion. You're going to do your practice as you please. And then you shortcut in a reasonable way. And then when you bang your thumb with the hammer, then you can use the F-bomb in a professional way. Right? But you're not kind of just reckless with the word, right? Because words always have meaning and impact on people, don't they? It seems kind of obvious and it seems kind of dull-witted to have to say that, but words do impact people in the way you phrase things significantly. We know that, right? If you have any loved ones at home and when they say stuff, you go, get offended by that or something like that, right? So another one, the OPQRSTs, what people use is another one. So pick one of these that really resonates with you and incorporate it in your practice and just learn it. Don't learn all of them, just, I made it for the quiz, you gotta be familiar with a few, but pick one and just stick with it in your practice. There's old cards. That's one I kind of use on there.
Yeah.
Yeah, you're familiar with that one? Yeah, she likes it. We got one for old cards. Be detailed. Sometimes you put pertinent negatives, not all the negatives, something that might be, we're also always doing in this, we're doing some risk assessment. This is kind of what this is. This interview is giving us information to determine risk of things. When you get